So this is the weekly wrap-up for last week, which was a focus on the respiratory assessment. And I'm just going to run through the book and point out some of the more important things that I want you to concentrate on, especially when you're thinking about studying for the test. First of all, take a look at some of the things that have to do with the anatomy and physiology. Of course, you need to be aware of where the lobes lie beneath the chest wall, and that way you can anticipate what lobe the abnormal sounds exist in so that you can document those appropriately. You also need to be familiar with the mechanics of breathing. The other thing that I think is important is the fact that past history is really, really important for the respiratory assessment. So you want to talk about family history, you want to talk about environmental and home exposure, and you want to talk about the risk factors. There is a good list of risk factors on page 186, and again, as we think about how much risk someone has placed themselves for respiratory disease, we want to assess those behaviors that are associated with cancer and exposure to radon and secondhand smoke, pollution, asbestos, and all those are listed there for you. Box 11-1 also talks about how to measure how much someone has smoked. And then if there is a symptom such as cough, we want to ask whether or not the cough is productive, describe the sputum, assess for shortness of breath, any type of pain with breathing. And for all of those symptoms, you can use the Olckarts mnemonic to assess all the parameters. There is also, starting on page 190, we discussed this in class, and it's important to make sure that you're assessing for things that could immediately cue you in on the fact that there may be a respiratory issue. So the appearance, the posture, the facial expression, the work of breathing, or the amount of effort that the patient has placed. Remember, for measuring respiratory rate, one respiration is an inspiration and an expiration. We're going to do it for 30 seconds, trying to make sure that the patient is not aware that we're actually counting the respiratory rate, and then multiplying it by 2. We also want to observe the breathing pattern. Really, I expect you to know the normal respiratory rate, and I want you to be familiar with the terms bradypnea and tachypnea. When you auscultate, the important thing is not keying in on exactly how many times you auscultate on each side, but it's important to go side to side, comparing each location that is symmetrically placed across from the one that you've just listened to. So listening in the same place in a side-to-side manner, and making sure that you're listening in all lobes, including anterior, posterior, and in the lateral positions. Be sure that as you're assessing, that you're also aware of what the normal variation of sound is and where those occur. So I need you to be familiar with the terms vesicular, bronchovesicular, and bronchial sounds. Talking about listening, on page 194, there is a box that describes adventitious sounds. And so I expect you to understand what crackles are, what they sound like, and what types of clinical problems produce those types of symptoms, as well as wheezing, bronchi, and a pleural friction rub. The other thing that you should be familiar with would be the shape of the thorax. So if someone has a barrel chest, what does that mean? And how is that caused? And what does it mean as far as what other parameters you would want to check for that would indicate that the patient potentially has an obstructive pulmonary disease, such as clubbing and pursed lip breathing. When you auscultate, be sure that you're going scope to skin. You are not supposed to be listening over clothing, ever. in this course. So that's an important thing to know. All right, we really didn't do palpation and percussion. Remember, if we were to see an abnormal skin lesion that needed to be palpated on the thorax or on the back, we would do it as an integrated part of this exam. And now let's go to chapter 11, page 202. You should be familiar with the common problems and conditions, and you should also take a look through the older adult chapter at the pulmonary section, because I want you to be familiar with some of the common changes that occur in an older adult. Let's see. I think that's it. Remember, when we listen to breath sounds, we use the diaphragm of the stethoscope, because the diaphragm is, of course, the part of the scope that we will use when listening to higher pitch sounds. The other thing that's really important about assessing someone who has changes in their respiratory status is understanding what hypoxia looks like. The difference between core and peripheral cyanosis and the early signs of hypoxia, and how we recognize those things, even in people with different skin tones. It's an important thing to know. I think that's it for this week. I hope the weekly wrap-up helps you focus on the important parts of the chapter, and I also hope you enjoyed listening with the stethoscope to the simulators and hearing some of the differences that occurred in our patient that we had as a simulated patient last week. Let's see. I'll be sending out an evaluation. I'm going to ask that you evaluate the lab last week and give me some feedback on whether you liked having a case and having the simulation to practice on. The other thing that we're going to be doing this week in class is learning blood pressure and how to take both a radial and apical pulse. So we're going to be doing a lot of practice in lab. We're going to be doing a lot of practice, but you're also going to need to be practicing at home. So be aware that the more you practice, the more accurate you are, and we'll be checking you off on those skills when you feel like you've had plenty of time to practice and you're accurate. All right. I'll see you guys in lab this week.